Okay. So thank you, sir. So traumatic brain injury. So welcome to all candidates after the festival season, and I hope we are on track regarding the studies. Some of you, those who haven't picked up the studies, it's the right time to start these studies because anyway, you are going to have, I think, 5, 6 months remaining before actual crash and orientation, crash and mocks come up. It's already November. So the purpose of all these classes, the weekly classes, anyway, in 1 hour, we can't give you all the details about a particular topic, but we can touch those aspects of that particular topic. Those are very, very relevant in your clinical practice and which, as a fellow, you need to know. And if there are some points we touch when you read through the textbook, so you can get a better idea and better understanding of those um facts. So today's session will start with traumatic brain injury. It is basically divided into two parts. Today's topic. The first part will cover will start from the basics because we have a FCCM candidates also. And in the later part, we'll touch those aspects of the topics which are a little more controversial because ethics students are also included in it. So it will be a more or less more interactive rather than just a presentation. I have my notes with me so that I can answer your questions. I have jotted it down so that I don't miss anything. If there is remaining, I can refer to them. So with that, we'll start. Also, a small note that this is a lecture on traumatic brain injury, not a session on neuromonitoring or ICP monitoring, how to neuromonitor, how to put an EVDs, or how to monitor the ICPs, the different ICP waves and all. We are not going to discuss. We are just going to focus on traumatic brain injury because neuromonitoring itself is a bigger topic. Uh, I think. Okay. So again, whenever we start a particular topic, why we chose that topic and why that topic is relevant, everybody should understand. So this is the United States data, which shows that it is in trauma is the leading cause of death in individuals within working populations. When 1 to 45 years old, it is one of the leading cause. And also in geriatric patients, as the number of geriatric patients are increasing, people are increasing, number of falls are also increasing. Also, because of the violence or gunshot injuries, the traumatic brain injury increasing. But in that trauma, if we consider between 1 to 45 years old, the functional populations, traumatic brain injury is the is the main cause of death in these patients. Means in trauma patient, if we consider the mortalities or morbidities, if one has traumatic brain injury, other patient don't have, they had a poorer prognosis or poorer outcome as compared to those without traumatic brain injury. That's why it is very, very important. And mind you, this is the United States data only. It varies from country to country. In India, where the population is so high, in developing countries where the density of population is so high, road traffic accidents are much more common than in developed countries. So the number of cases seems to be very high. So, with that background, straight away coming to the focus of today's topic, that there are, in whenever we talk about traumatic brain injury, two aspects we are discussing. One, the impact which has happened at the time of injury, at the time of collision, or at the time of gunshot, or at the time of blast injury, anything which has happened at the time of injury per se. The main focus of a treating physician or the paramedics or the intensive care team or the critical care team is to prevent the secondary injury which happens after the primary injury. So at the time of injury impact, what injuries occur, we call that primary injury. It could be skull laceration, fractures, contusion, lacerations, intracranial hemorrhage, diffuse axonal injury. This has happened. You can't do anything about it. But what you can do is prevent all the components of the second injury, which will lead to a poor outcome, or which can prevent the brain and make a difference in the patient's functional outcome. So what there can be, intracranial pressures, hypoxia, hypotension, hypothermia, electrolyte dispersion. Basically, you are optimizing the physiology specifically of the brain for that particular patients. That is more important. So the whole purpose of understanding traumatic brain injury session is to optimize and minimize the secondary brain injuries per se. And secondary brain injury doesn't happen just after few minutes or few hours. They may take few days to develop. They may take for a few weeks also. For initial first week, they can develop like contusions. They develop after, contusions with brain edema, develop gradually over a period of 3-4 days, like that. While some diffuse axonal injury, they take a few weeks to evolve. So it is not just that we have to prevent just at the time or 1 or 2 days. We need to be aggressive, but we need to continue this physiological management throughout the course in intensive care. Now, pathophysiology, you understand that whenever we're talking about pathophysiology, try to keep it very simple. You have three components in the brain. One is your brain tissue. The other one is the brain parenchyma, sorry, CSF, which is holding that brain. And then you have blood. So you have three components, the brain, CSF, and blood. The theory says that all at a particular point of time, the volume of all these three remains constants. If there is a if CSF, more CSF is there, then either the brain tissue will compress, or the blood vasculature will compress. If there is a more blood there like hematoma or everything, brain tissue and CSF both get compromised. So the at total volume within the skull remains constant, and that is what creates a problem. If you see our skin, it is above the bone, it can expand, but brain cannot be expand because it is protected by the skull. So anything which comes extra in the brain, it may tries to keep, because the skull volume is constant, it cannot expand, and it increases the intracranial pressure, and which is the problem in traumatic brain injury. That's the main cause. And brain has a very wonderful mechanism which we call as cerebral autoregulation. Cerebral autoregulation means we have a blood pressure variation throughout the day and night, blood pressure variation in terms of trauma, in terms of injuries, in terms of fever, or any condition like that. So cerebral autoregulation maintains adjusted accordingly so that the cerebral perfusion pressure, means the pressure which is actually perfusing the brain, remains constant. So what is cerebral perfusion pressure? Cerebral perfusion pressure means your mean arterial pressure, which is perfusing the different organs of the body, minus the intracranial pressure, which is less than very less, 10 to somewhere around 10, 12, like that. If it is more than 20, we call it intracranial hypertension. So cerebral perfusion pressure is maintained by the cerebral autoregulation, and this is the mechanism which is lost during traumatic brain injuries, because the disruption of blood-brain barrier, there is a extra tissue inside the brain, extra blood inside the brain, extra infection inside the brain, and therefore the cerebral autoregulation fails. That's why the perfusing pressure of the brain gets compromised, which leads to secondary injuries. So that's what it is written. So whole of this session focuses on managing the intracranial pressure, mean arterial pressure, and preventing the cerebral edema. Because if we prevent the cerebral edema, if we prevent the intracranial pressure, we can maintain the cerebral perfusion pressure, and that's what our lecture is about. Now, I told you that cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. So either two things happen. Mean arterial pressure goes down, cerebral perfusion pressure decreases. Intracranial pressure goes up, then cerebral perfusion pressure decreases. So the technique is prevent the hypotension and prevent the raised intracranial pressure. You don't need to increase a mean arterial pressure beyond a certain point so that you want to increase the cerebral perfusion pressure. That is not recommended. You optimize the intracranial pressure. Now, 3-4 slides to make you understand regarding the various injuries. You need to understand the meningeal structure of the brain. So very simple diagram that I think many of you must have known, but it's a revision for me and few people who wants to understand. This is the scalp. This is your skull. This is your dura mater. These both blue are dura mater. One is attached to your periosteal, means ostium, and one is attached to the below layer, arachnoid, meningeal dura mater. This is meningeal. Then there is a arachnoid membrane, and then there is a pia mater. You say, and there is a brain. So based on this, we'll classify different types of injuries. So scalp, you have a skull, you have a dura mater, two layers of dura mater, periosteal and meningeal. This is important when we classify the types of injury. Then you have cervicoid matter, and then you have pia mater. Same, a more elaborated diagram. This is your skin and fatty tissue, veins are there. Then this is your skull. This is, you can see this, if my arrow is visible, this is dura mater, which is attached to the bone, which is periosteal, and this is one which is attached to the meningeal. You can see that it is attached where the suture line of the bone is there. This periosteal layer is attached very firmly, and the importance is the between the skull and the dura mater, there is an arterial supply, middle meningeal arteries and other major vessels which are running. So anything, any injury here, it's an arterial blood. Between dura mater and the brain tissue, there are venous plexus like this. So this is, it's a venous blood when we talk about subdural. In arachnoid space, subarachnoid space, there is arterial and venous, both are there. And of course, there is a brain parenchyma. Again, a 2D diagram showing the same. You have skull, you have skin, skull, dura mater attached to the bone, periosteal, dura mater attached to the meninges. Then and you have subarachnoid and pia mater. Very, very important. Again and again and again. Cranium, you have dura mater, endosteal layer, dura mater, which is a meningeal layer. This is your subdural space. This is an arachnoid membrane. This is subarachnoid space, and there is a pia mater. So this will classify the types of injuries. So what types of injuries can have? Anybody having any question can put it in the chat box. I will take the questions later on. So there are 4 or 5 types of injuries which occur in traumatic brain injury. The first one is which is very life-threatening as well as very rewarding to treat is EDH, extradural hemorrhage. Extradural hemorrhage means it is beyond the dura, outside the dura. So where it will happen? It will happen outside the dura, between the skull and the periosteal. So why important? Because in between the skull and the dura mater. So here it is periosteal layer of dura mater attached to the suture line. So, and it's an arterial blood. So it expands very rapidly. You see, this is a small EDH. It is not compromising the brain parenchyma, means intracranial, it's not creating midline shift, but it is a lens-shaped structure, which is an arterial blood. One has to remember that EDH is an arterial blood or pathology, and therefore it can expand very rapidly. It is very, very important. Second thing regarding the EDH is usually near the temporal or parietal area. It is there. In most of the patient, it is near the parietal area. Thirdly, the patient can have a lucid interval in EDH. Lucid intervals mean there is a period of unconsciousness. Then the patient regain full consciousness. Patient will seem very fine. You did a scan and the patient looks like very comfortable, and you say that there is small DDH and nothing needs to worry, just maintain conservative, and suddenly patient collapses. It expands very rapidly. So EDH patient needs to be very, very carefully observed in the intensive care. Now, typically, these occur in the young individuals. Old individual geriatric patients, usually you have an SDH sort of pathology. Now, this is subdural hemorrhage. You see, this EDH doesn't cross the suture line because the dura mater is very, very firmly attached to the periosteum. While this is subdural. Subdural means between the dura and the meningeal layer. So it is a venous structure, venous sinuses are there, and there is a slow, gradually increasing blood, and it doesn't follow the suture line. So sorry. So you can see that it starts here and it's a crescentic shaped structure. It was previous was a lens shaped structure, and this is a crescentic shaped structure, slowly progressing, putting in pressure on the right side of the brain, and this requires this patient craniectomy at this stage. Now, this can be acute, subacute, and chronic. Why it is important? Acute, you will pick on the CT scan that it is very bright. Subacute, you will pick that it is black as compared to gray matter. While the subacute one, especially the patients who are antiplatelets or alcoholics or cirrhotic or any anticoagulation, they have a very small, very even with a very small trivial trauma, like sitting and getting their head struck with the on the bed or on the wall, or there is some very trivial injury while playing or something, the venous blood start getting oozing and it starts collecting. And when it becomes subacute, it is very almost of the same color as means the density is almost equal to that of the brain parenchyma. So it is likely that the new trainees miss this subdural hematoma. So acute one you will pick, it is very bright. Subacute, chances are of missing are there. And then chronic one, it is more or like this CSF. So always try to figure out whether it is acute, subacute, or mixed. The characteristics of a SDH is that they can expand very rapidly or they can expand slowly, but EDH expand very rapidly. Also, the prognosis of SDH is a little low or worse than the EDH, because EDH is very easy to identify and easy to treat. Neurological recovery is very fast because the brain parenchyma is intact, it's above the dura. Here, the brain parenchyma is also, you can have seizures, you can have slow pathology sort of things. In geriatric patients, this is more common because the brain shrinks and there is a stretch on the venous structure. So any trivial trauma, and usually there are coronary medications. So both the factors make SDH more common in the elderly. I'm keeping it a little slow, but we'll finish in the time so that most of the doubts are clear in this session. Also, mind you, those for FCCM candidates, these type of OSCEs can come in your this type of income in your OSCEs also. Now, the third is, I think I have put a wrong picture. Um, it looks like more of contusions rather than SH. So, my bad. So, not a classical image of subarachnoid hemorrhage, but subarachnoid hemorrhage happens in the subarachnoid space, and most of them are traumatic, and in non-traumatic causes there are aneurysmal causes, but in traumatic cases they are usually near the surface like this. Just a second, just a second. So these traumatic SH are usually peripheral, as you can see there, and they are in the subarachnoid space, yeah, like this, and they are more prone to the same complications of SH like vasospasm and seizures like that. So keep a close watch. Then contusions. Usually the brain contusion, they occur usually near the what you call as where near the basilar skull or the temporal regions, because the bony structure is not uniform there. So whenever there is a very large impact, either near the bone in the periphery or at the base of the skull, there will be different contusions. The importance of these contusions is that they may not be evident very large on day one. You may find that it is a very small contusion, or nothing need to worry, patient is fine. But they expand and the edema develops around this contusion over a period of 48 to 72 hours, and they can be such that they can be very detrimental. So whenever a patient has contusions, always keep a watch in next 72 to 96 hours that they can expand, or at least the edema can expand and they can deteriorate, especially in the temporal region. The space is very less, and even if a small increase in the size of contusions or edema, the patient can deteriorate very fast. So this is very, very important. Now, basally, skull fractures, obviously, skull fracture are also common at the base of the skull, usually at the top of the in the frontal bones or in the temporal bones. They are not of much significance, much I would say problem, until unless they are very depressed fractures which is hitting the parenchyma. But if there is a fracture of the base of the skull or the cribriform plate, there is a high chance that this can lead to breach in the cribriform plate, and the pathogens can travel through them, and it can cause CSF rhinorrhea and meningitis. So this is something very, very important in case of basal skull fracture, which we need to remember. Near the mastoid region, cribriform plate, all these area can lead to meningitis. Now, the last one, well, a common one is diffuse axonal injury. So, whenever there is shearing state where the gray matter and white matter junction is there, where the dendrites are converting into axons, there occurs small punctate hemorrhage sort of thing, which we call as diffuse brain injury. They may not be evident very much on the CT scan, but on MRI, they are visible, and usually they are not visible on day one. They take time to evolve on the third, fourth day. If the patient is not so clinically alert, or as compared to the scan, means if the patient is clinically down but your scan shows that the patient there is no major injury, then you should get an MRI done, because chances are there that the patient may be having diffuse axonal injury. Diffuse means all over the brain, axons means you understand, and there is an injury. So recovery from diffuse axonal injury varies, but usually it's not very fast. It takes time, but we have to manage all those things. So these were the forms of different sorts of injuries. CT scan is the modality of choice to diagnose. So whenever a patient comes, if you have a low GCS 13, 14, get a CT scan done. If you go in the Western world, where the UK, where there is a strict protocol for getting a CT scan done, when to get a CT scan done. So there are GCS scaling. If the GCS is down, or you find any evidence that this patient may have a raised ICP, something, then you should go for a CT scan. While in our part of the country, because facilities available, and usually it is done most of the time on day one in the ER, and MRI is only done in case MRI will give you detailing, but it is recommended after on the third or fourth day, when you suspect diffuse axonal injury or want to see that soft tissue injuries or detailing of those things, but it's not recommended on day one. Now, how to classify the severity of traumatic brain injury? So very, very difficult per se to put one patient in particular category, but there are many factors involved. Severity, how is the diffuse axonal injury, how is the trauma, what was the impact, whether it's a large EDH, small SDH, or contusion. But for the sake of communication between different people, you need to have a system where you need to identify that, oh, this patient is more or less okay, this patient is severe. So they identify, categorize the on the basis of GCS scoring, which is the easiest one they can do. So if the GCS scale is 13 to 15, it's a mild injury, 9 to 12, moderate injury, and less than 9, it's severe. And in GCS scoring also, for all FCCM candidates, the motor one carries the highest value in terms of long-term prognosis. So if you have two patients, both of them have GCS of what you say, suppose 11, but one having a M5 response, and other is having M3 response. So the motor one, which is having an M5 response, has a better prognosis in long term as compared to the person having the M3. Also, the assessment of GCS on the admission is confounded by many things. You can have alcohol, drug, shock, maybe the person may be in the having some drug or alcohol, and he may not be evident on day one, but on day two, day three, you find that this is better. So GCS scoring per se is a tool to communicate and document certain things, but the severity varies, depends upon a lot of other factors. If the patient is having other type of shock or spinal injury also, that is different. So that's what I was saying. Just a second. So what happened there, on the trauma side, there could be patient may be having hematoma, or the patient having a contusion or diffuse axonal injury, plus hypoxemia, because the patient may not be able to breathe at the accident site. So these are systemic insults which can happen. And what all these things lead to, they lead to swelling, the swelling of the brain. And once the swelling of the brain happens, it causes the raised intracranial pressure. And because of the raised intracranial pressure, the cerebral perfusion pressure drops. Because why it drops? Because mean arterial pressure is constant, intracranial pressure is increased, so cerebral perfusion drops, and this causes the cells to suffer further injury, hypoxia, ischemia, and this vicious cycle goes on. So intracranial hypertension, you will say more than 12, but intracranial, if it is more than 20, then it is a raised ICP. Then it's a thing which is very, very alarming. And your target should be to keep the cerebral perfusion pressure somewhere around 60 to 70. Okay. Now, before we discuss the hospital management, if you are guiding a paramedic, or you live in a rural area where you are referring the patient, certain things you need to remember while transferring this patient, the pre-hospital management, which you say, you prevent three main things. You prevent the hypotension, you prevent the raised PCO2, and you prevent the hypoxemia. So oxygen, carbon dioxide, and blood pressure. Just take care of these three things while the patient getting shifted to some other hospital, higher center. It will take care of the most of the things. It will prevent the secondary injury to triage according to severity, secure the airway, either by rapid sequence intubation or cricothyrotomy, because some patient may have facial injury also, spine injury also. You may not be able to intubate. So cricothyrotomy comes into play. Any patient, so when to intubate? Any patient in whom you feel that this patient can have a compromised airway, the GCS down, this patient may aspirate, there is a low GCS. Ideally, they say, according to the books, if the GCS is less than 8, you should intubate. But in trauma patient, you don't know the patient who's having a GCS of 11, the patient has suffered an injury, the patient is risk of aspirating, the hematoma can expand. During the travel, this patient can collapse, or the injury can expand. You intubate the patient and send. Securing the airway is something which will take care of your oxygenation. It takes care of the carbon dioxide and prevents further permanent brain damage. Something. Securing the spine, not just the cervical spine. Cervical spine, though, is very mandatory, because it is very nearby and it can get injured. So hard collar should be put, but make sure it should not be too hard, which so that the venous drainage is compromised. But for initially, you just put in a hard collar. But if you want to secure the spine, how do we do that? On the hard surface, you transport the patients, and immobilization on a long spine. Now, third thing, which is very, very practiced at certain places, not practiced at a hyperventilation. Hyperventilation means bringing the PCO2 down below 30, so that the intracranial pressure will not increase. Why? Because what happens that PCO2 is a vasodilator in the brain. So if there is a large PCO2, higher PCO2, it will venodilate and cause the raised ICP. While if we decrease the PCO2, there will be venoconstriction. It will increase and decrease the intracranial pressure. That is a theoretical aspect. But hyperventilating the patient to an extent that bringing the PCO2 less than 30 causes venoconstriction and ischemia and can further aggravate the injury. So it is only and only and only recommended in the initial stages when you think there is a raised ICP and there is no other options left. We have tried sedation, we have tried hyperosmotic agent, we have tried mannitol, we have tried everything which we have given, we have controlled the fever, everything, then you hyperventilate and then shift. But it is usually within 3 hours, it's beneficial, otherwise no role. Avoid hypotension. We see hypercarbia prevention, hypoxia, and hypotension. So avoid hypotension. Usually, the patient's trauma have blood loss, if possible, transfuse bloods, and if not available, crystalloids, no colloids, no role of aluminum or other things, just crystalloids, perfuse it, and then shift. Sorry. Hmm. Now, goal-directed management in TBI. Once the patient has reached your hospital and now got you have done the scanning or whatever, it's whatever injury, it's EDH, SDH, etc. And now it's in the ICU and you need to monitor the patient. So you have 4 or 5 things which you need to do very. You have neurological goal-directed therapy, you have respiratory goal-directed therapy, hemodynamics, and electrolyte. So what you will do is keep the saturations above 95%. You need to make sure that the on ventilator or with any thing, no role of NIV in head injury. Just make sure either the patient is on simple oxygen or either the patient is on ventilation. There is no role of NIV because the patient is neurologically down, will aspirate. There is associated injuries, will not be able to coordinate. So either you are intubating the patient or you are on the room air or simple oxygen. No role of NIV. So keep a pulse oximetry saturation of 95, PO2 somewhere around 80 to 100. You should keep PCO2. It is written 35 to 45 in normal circumstances. But when you are thinking of on a patient who has raised ICP and you have put the patient on ventilator, somewhere around 35 is a better choice as compared to 45, because at 35 neither you are hyperventilating, 32 to 35, but neither you are hypoventilating, and you will create an optimum value of PCO2. To do that, you can also do by ABG frequent monitoring, or if you have ETCO2 available in your ICUs, you can connect that and you can manage it in a dynamic way. We'll discuss this. Systolic blood pressure should be, mind you, this is not mean arterial pressure. This is systolic blood pressure, which needs to be keep equal or more than 100. Here we are not talking about the permissive hypotension, which is there in the other forms of trauma patient. In traumatic brain injury, to perfuse the brain, you need to keep the systolic blood pressure more than 100. pH, obviously, everybody knows that we need to help. ICP below 20. It is written 2025, but with below 20, we need to keep it. This is brain tissue oxygenation, advanced monitoring. If it is oxygenation is more than 15, it is fine. If it is less, less. Cerebral perfusion pressure more than 60. Temperature, no role of hypothermia. You just keep the patient euthermic. If there is a fever, treat it aggressively. Glucose, no role of strict glucose monitoring. You need to keep it somewhere around 150 to 180. The reason is, we'll discuss this later also, why it is important. Sodium levels, usually these patients have hypernatremia, but don't make the patients hyponatremic. Keep in the normal range. INR platelets should be in the normal range, and hemoglobin above 7. So these are the generalized rules. If you are, if in Viva we ask you what are the general rules, parameters, goal-directed parameters, these are the targets. We need to know that we need to keep hemoglobin above 7, PCO2 like this, cerebral perfusion pressure. These should be cut. You need to remember. Now, how do we monitor intracranial pressure? So why it is important? There are many tools available, like for which patients you need to have intracranial pressure monitoring. Means you put an EVD and then measure the intracranial pressure. You put a parenchymal probe and measure the intracranial pressure, or you have a brain tissue oxygenation, which is in advanced neuromonitoring setup. Any of them is more beneficial than other. So first of all, you need to think that in who are the patients in which I need to do intracranial pressure monitoring. So any patient who has GCS of less than 8, means you are ventilating a patient, then obviously you should do a intracranial monitoring if it is available. In patients who have a GCS of more than 8, but you feel that they are a high risk of progression, you should start intracranial pressure monitoring. But there is a trial called, just a second, let me check and tell you. The trial name was, sorry, Best Trip. There was a benchmark evidence from South American trials, treatment of intracranial pressure trial. So, best trip trial, which shows that the clinical observation is no inferior to these all invasive monitoring devices. So, even if your setup has something, no ICP monitoring device, be assured that your clinical judgment, Cushing reflex, there is a bradycardia, hypertension, pupillary monitoring, um, any other signs of raised intracranial pressure, preventing secondary injury is still very much important in monitoring, in neuro monitoring the patients. So the clinical monitoring is very important. Now, out of the monitoring devices, extraventricular drainage, a pipe which is put in the ventricles, is preferred. Why? Because first, it is easily can be done. Secondly, it gives you therapeutic option. If there is a raised intracranial pressure, they can drain out a little bit of CSF through EVD. While intraparenchymal monitoring is also easy, but it doesn't give you a therapeutic advantage over there. Okay. Now you have a patient, you have set the targeted goals, you are maintaining all the hemostatic things of the patients, and now you are monitoring the intracranial pressure also, and now you find that this intracranial pressure is increasing. My patient is deteriorating. So how will you manage it? So for simplicity, we have classified into first tier management, second tier management, third tier management. So first tier management means position the patient correctly. Don't make it a flat supine. Keep it in a little head elevated positions. The head of the patient should be elevated proper and around 30 degree, and make sure that it is not on one side. Both neck should be straight so that both the jugular venous pressure, veins drain the blood. Now, what if the cervical spine injury is there, or if there is a spinal injury is there? You cannot move the patient. So for that, the solution is reverse Trendelenburg position. This is a Trendelenburg position. This is reverse Trendelenburg position. So from on the bed, you can move it like that. This is a straight spine is not compromised, but the jugular venous drainage is there. So that's the thing. So position the patient, give sedation, midazolam, fentanyl can be used. You have other molecules also, but they are not used in initial stages. Give proper sedation, analgesia. The term which is Anglo sedation, analgesia and sedation is better compared to either sedation alone or analgesia. Keep on continuous infusions. If there is, if still you feel a small amount of CSF can be dealt, if the EVD is still in place, if for particular surgery they have placed an EVD, you can drain a little bit amount of CSF. And if you are draining the CSF, important thing I want to tell you that where it should be kept. This is your patient, and this is tragus of the ear. And the tragus of the ear should be in line with the transducer of your EVD. Not here, not the here, not with the bag. You should see the transducer. Where is the transducer of this particular thing? Where the transducer, and this should be this. This will help you to measure the intracranial pressure. Now you have tried all these things, and now the second tier management starts. Still, you are not able to control the. Now comes the role of your osmotic agents. What are the osmotic agents? Mannitol versus saline. Now, the beauty of mannitol is we'll come in a short while discuss a few interesting facts about. But bolus doses of osmotic agents, whether mannitol or saline, are recommended. The reason is it creates a osmolar shift, means tonicity shift. It draws water from the interparenchyma to the intravascular compartment and makes the intracranial pressure fall. Secondly, is a volume expander. Also, it takes care of the perfusion for initial period of time. But as this is osmotic diuretic also, so it can drain the patients, make the patients hypovolemic also. So you need to check the fluids also. So if for any but it's a renal toxic, but if you can't use this for hypotension, if the patient hypertension or renal injury, you want to use hypertonic saline, there are various available. The literature always talks about 7.5% or 23.5% hypertonic saline. 3% saline is never ever I have read where it is maintained, but most of the practice, oh sorry, 10% saline, but most of the things are about 23.5% saline. So you can try that. Bolus doses are there. One fact which I read and found that the continuous infusion is not very superior after 2 or 3 days as compared to bolus doses of saline, hypertonic saline. Because what happens over a period of time, the intravascular and extravascular compartment both gets in equilibrium, and it doesn't draws the water from the intercellular compartment to the intravascular compartment. Therefore, bolus doses are much more helpful as compared to things. Now, brief period of hyperventilation. If it is not you are not able to manage, then brief period of hyperventilation you can try, and by the time you prepare for the third try of management, which is barbiturate coma, phenobarbital, propofol, both of them can be tried. But the problem with phenobarbital is hypotension. Same with the propofol. And phenobarbital also has a problem that it is a longer half life. It takes time from the body to get released. So at times, if the patient, you think this patient may be in going in a state of brain dead sort of thing, then the assessment becomes difficult, because then you need to figure out what are the drug level in this patient. You need to find out whether this patient is under the effect of phenobarbital or not. It's very difficult. And with propofol, the problem is propofol related infusion syndrome, which is a severe metabolic acidosis, rhabdomyolysis, and which can cause life-threatening condition. And if all these fails, then you have role of surgical intervention, whether evacuation of the hematoma or decompressive craniotomy. So these are the things you need to try. So optimize the patient physiologically, then monitor and continue monitoring ICP. And once you have monitor ICP, you find, so you have tier 1, tier 2, and tier 3 things. So this is a small algorithm, just a quick go through. All patient endotracheal intubation in which you feel head of the bed elevated 30 to 45, reverse elbow patient, spine patient, maintain the head in neutral position, that's the right term. Systolic blood pressure more than 100, it require 110. If there is impending signs of herniation, which is raised ICP, pupillary asymmetry is there, or there is a fixed pupil, or there is a decerebrate posting, the GCS motor response was 5, M4, 5, now it has started decerebrating, or the patient is getting a respiratory depressions, or there is a Cushing triad, there is a hypertension, bradycardia, and irregular respirations. These are signs of raised ICP. Then you should think that this patient is landing in raised ICP. What you can do that, immediate measures, what you hyperventilate for a very small brief period of time, monitor the CO2 somewhere around 30, not less than that. Give a bolus dose of mannitol or 3% saline, maintain the blood pressure. These are short term. You know? And once you have tried that, then neurosurgical intervention, evacuation intracranial hematoma. If it's still, then you drain the CSF, maintain the perfusion. Still fails, continue osmotic therapy. And if still fails, then you can have decompressive craniotomy. So this way you follow. Special considerations, penetrating injuries and elderly. In elderly, it's very unpredictable. The prognosis is very unpredictable because of their age and so comorbid conditions. So you need to be extra cautious for them. Penetrating injuries are why I put it then, because there are gunshot injuries which are increasing nowadays very frequently in the Western world also. So there are 2, 3 impacts. One is because of the bullet per se, piercing. Second is because of the blast wave which carries. Thirdly, because of the metals are there. So you, if the patient GCS is maintained, don't do surgical intervention just for the sake of removing. Monitor it. If it's a very low GCS, then obviously you need to consider the surgeon and do that. Now, prognosis after TBI. Lot of criteria are there: MRI, CT, low GCS, comorbid condition. But whatever the literatures say, that in the end, in traumatic brain injury, it's very, very difficult to predict either a bad outcome or good outcome at that. So a multidisciplinary team approach, discussion with the family, the positive, negatives, these to be done. So never ever prognosticate too positively or too negatively. Keep an optimized thing while you're counseling the patients. So this was the part one of today's session, and now we'll start the part two, which is more interesting. It will not take time, but it's a little much better. Permissive hypertension. We have discussed. I told you that in trauma patients, what happens that there is a term which is coming up, damage control permissive hypertension and damage control surgery means they keep the perfusion pressure, systolic blood pressure less than 90 or somewhere around 90 so that the bleeding is prevented. But they excluded the patients who were of traumatic brain injury, because in traumatic brain injury, what happens? The brain perfusion is compromised if we don't maintain the mean arterial pressure or systolic blood pressure. So if you are dealing with a traumatic brain injury patient, you need to keep systolic blood pressure above 100 and 110. Don't get into the way of maintaining a permissive hypotension in such patients. So if we have a trauma with a head injury and abdominal injury, keep it as a priority that you will keep maintain somewhere around 100 and 110. Not much of difference, but you keep it like that. Source control. Steroids. Many people prefer to give steroids for brain edema. Is it required? Is it helpful? No. Whatever the literature says that don't give steroids in case of traumatic brain injury to prevent the edema. It is detrimental. So steroids should not be used just for the sake of reducing the edema in traumatic brain injury. Third question, which is hypertonic saline or balanced crystalloids during resuscitation. Suppose, obviously, so the dictum is whenever the patient is in shock, you need to maintain the intravascular compartment. So the best you can maintain with a fluid which has the maximum solute load, and that is a normal saline. So give iso. I should have written it is isotonic saline rather than hypotonic. So give isotonic saline, fluid resuscitate the patient, and once the patient is hemodynamic stable, then you think whether I should give hypotonic saline or now balanced solutions. So those who are listening, very, very important point is, suppose these patients are of traumatic brain injury are at the risk of developing hypernatremia because of the DI or because of the fever or because of the poor thirst mechanism. So it happens that because of reducing the brain edema, you are already giving it a hypertonic saline and you are resuscitating the fluid. And now suppose the sodium goes up to 155 or 160. Now the question is whether I should switch to dextrose containing or hypotonic saline 0.5. This is a concept which when I read also was surprising to me, but it's a good one. That's why I'm sharing. It is written that even if your sodium goes up in a patient, then also you should not opt for hypotonic solutions in a patients of traumatic brain injury because it can lead to edema. Rather than switching to your hypotonic solution, you try to think and see for what reason the sodium is increasing. You try to counter those mechanisms rather than just by switching to hypotonic saline. So don't switch to 0.45% saline, which we also started practicing. We had a discussion with neurology most of the time on this, but I think he was right. So don't switch to hypotonic solutions. Always prefer isotonic solutions in that. Second concept was that the major concern of isotonic fluids is they will cause normal anion gap metabolic acidosis, which is hyperchloremic metabolic acidosis. So when they saw whether the problem in these patients is because of hypernatremia or whether because of hyperchloremia, so they found that it's the chloride which is causing a major concern. So if the solution is containing a good amount of sodium and acetate is there in the solution, you can opt for that. But don't switch to hypotonic solutions per se. It should have a good sodium content. If our normal saline contains 145, 154 somewhere. So if something is there 130, 134, 135 some solution, you can with acetate you can switch, but don't go to sodium of 90 or less than that. So this clears. So isotonic saline should be used. Now, mannitol versus hypertonic saline for reducing the which is preferred. So, regarding mannitol is good one if the patient is maintaining blood pressure. If there is a no compromise in the renal path, renal not compromised, give mannitol. It will expand the volume, bring the fluid from intracellular compartment to the intravascular compartment, expand the volume, flush and will go through the kidneys outside the body, so it reduces the intracranial pressure. Now, the other controversy regarding the mannitol is mannitol leak controversy. Means the part of the brain which is damaged, where there is a vascular damage, mannitol can go there also. And if the mannitol can go in that part of the brain which is damaged, where the vascularies are damaged, which is extravascular, it will bring the fluid there also. So this was a lot of debate on this, but now what they have seen that mannitol goes there, but as soon as the other part, mannitol starts getting out of the body, mannitol get clears from that area also. So it doesn't cause a counter effect mechanism which increases the brain edema. So in that part, the mannitol is safe, but the problem with mannitol is it can cause hypotension because it's an osmotic diuretic. Secondly, it causes renal failure. So if we can't use, if the patient is in hypotension or if the patient is renally compromised, then you should use hypertonic saline. So hypertonic saline, you should give bolus or continuous infusion. So all the literature is saying that you should try to give them as a bolus, because what happens if you maintain a persistent high sodium level on a continuous infusion, the intravascular compartment and the intracellular compartment will get become in equilibrium, and they will not draw the water from intracellular compartment to the intravascular compartment. So giving hypertonic saline as a bolus is much better than giving the as a continuous infusion. Seizure prophylaxis. So whether you should give seizure prophylaxis or not to such patient, yes. These patients are at risk of developing seizure. So they can, if you feel that the brain interparenchyma is involved, for 7 days, they recommend that you should give prophylaxis. And if you feel the patient is comfortable, they can be abruptly stopped. They no need to continue. Which agent should be used? Phenytoin can be used. But because of safety profile, levetiracetam is also used. Some patients on levetiracetam may show a little bit of agitation, which is detrimental in traumatic brain injury. So for such patients, you can use valproic acid. But nowadays, levetiracetam is the standard, which is given safer to use. Some case reports of hyponatremia with levetiracetam is there, but we haven't seen this many. But if you get an unexplained cause, you can think of. Reversal of anticoagulation, antiplatelets. So this is something very, very interesting. Because of this, I thought of just a second. Means anticoagulation, if the patient is on some vitamin K antagonist for valvular thing, if the patient is there, whether you will reverse or not. So you have 2, 3 options. Either you can give vitamin K agonist, or you can give fresh frozen plasma, or you can give prothrombin complex concentrate for such patients. So in Western world, what they say that instead of giving fresh frozen plasma, which takes time to get arranged, you give prothrombin complex concentrate, and this has a better efficacy as compared to fresh frozen plasma. In our part of country, because it is not funded by the government, patient at times don't agree, means it's costly affair. So we try to get FFE and gets arranged within 2 or 3 hours. But if it is available, PCC is the recommended thing for reversal of anticoagulation. If the patient is on dabigatran or any other thing, the specific antidotes are available, which can be given to reverse, especially if the patient is going under surgery. So you need to reverse it. Then antiplatelet, the patient elderly on ecosprin or antiplatelets are there. So whether we should give reversal or not. So they found that whether we give it the patient anti-platelet transfusion or not, it has no effect on the even on the surgery or even on the outcome. But because it's a thought on the surgeon's mind that this may bleed during surgery, the practice still is that they transfuse for satisfaction platelets and do the surgery. But if somebody says that one is not requiring platelets for we can go without any platelet transfusion, you can go ahead, because the guidelines say that there is no effect of transfusing platelets per se for in traumatic brain injury if the platelets are normal. Obviously, if the patient, suppose if a dengue patient and have a trauma and there's a bleed, there is thrombocytopenia. For that matter, you need to transfuse those platelets. You need to maintain them at a particular level. Also, if the patient is on what you call that on that inhibitor, GP2A, 3B inhibitors, the transfusion of platelets will not have any effect because they get neutralized in the blood. So platelets should only be transfused if the surgeon says, but per se, it is not recommended we should transfuse platelet because the patient was on antiplatelets. For anticoagulation, if the INR is above 1.4, you should give PCC or fresh frozen plasma. Now, surgical hematoma evacuation, should we do it? I'm not talking about decompressive craniotomy. I'm talking about the evacuation of hematoma. So surgical hematoma evacuation is not recommended until and unless it's threatening the life of the patient, because they say that you are breaching the parenchyma, you are removing and it is creating a more problem as compared to normal recovery. Surgical hematoma evacuation is usually not recommended. Decompressive craniotomy is much better option. Now, decompressive craniotomy timing. What should be the timing of decompressive? You have a young patient, GCS 10, 11, there is a slight brain edema. You think whether we should do a craniotomy or we should not do a craniotomy, or there are patients who there is a raised ICP, we should do early decompressive craniotomy, or we should wait till the patient deteriorates and we do a decompressive craniotomy. So these are the answers. So first thing, in the trials, they found that doing early versus late decompressive craniotomy or prophylactic craniotomy has got no role. It's case to case basis. You decide clinically whether you require or not, but just for the sake prophylactic craniotomy we do, so that ICP doesn't make any chance in the long term outcome or the mortality. Second, for raised ICP, if they say that if they do a decompressive craniotomy as an over enthusiastic measure, the raised ICP, there is a pupil is dilated and geriatric patient, if do a decompressive craniotomy, they and if the ICP monitor is showing the raised ICP, if we are doing it, the patients may survive, but the overall functional outcome is not good. They may remain dependent on the nursing home or the family members for a longer period of time. So this was the catch, that they may survive the initial phase, but the long-term outcome is not very good in such patients. So decompressive craniotomy should be done as a life-saving procedures, not to improve the functional outcomes. It should be very, very clear, but it is much better than evacuation of the hematoma. Now, multimodality neuromonitoring versus clinical observation. So I told you the trial name, which says that clinical observations are still very good by pupillary reflex, Cushing reflex, BP monitoring, all those things which we saw in that algorithm. They are still holds a very good value in monitoring the neuromonitoring the patients. Hypothermia, whether traumatic brain injury patients should be maintain a temperature less than 34, 32, 33. So it is a well-known fact that putting the patient in a hypothermia produces the ICP, but it doesn't translate into long-term outcome. Rather, it develops other complication, coagulation problems, infections, hyperglycemia sort of things. So what they say is you just maintain euthermia, 36, 37 degrees centigrade, treat the fever aggressively. In other cases where is sepsis, where we treat fever only whether it is 101 like that, and we give paracetamol and then we cover with the antibiotics. Here, if the temperature is getting beyond 37, even if you don't know it can be central in origin, give round the clock paracetamol to keep the patient euthermic. Hyperthermia is more detrimental, so it should not be case. Continue with your antibiotics. Prophylactically pharmacologically induced coma. you feel that this patient is going into a raised ICP sort of condition, and we should ventilate and skip the second tier therapy, and we should straight away go to the third tier and should keep the patient on barbiturate coma straight away. You tried first thing without even giving 3% or like that. Prophylactically, we should put the patient on therapeutic coma, phenobarbital or propofol infusion. No, it has got no role. It may worsen it. They should only be tried when there is a very severe ICP, and it is not getting control on from tier 1 or tier 2 therapies. Hypoxia, whether how much oxygenation level should you maintain? 100%? No. 94, 95 is fair enough. We should maintain. Do not give hyperoxemia. In kids, hyperoxemia is very detrimental. Same in adults. When the blood brain barrier is damaged, oxygen radicals can damage the brain. So keep oxygen levels in the normal range. Don't over enthusiastically chase it. Sorry. Hypercarbia and hypocarbia. Obviously, hypercarbia is not recommended. Means PCO2 levels above 45 still not acceptable. But hypocarbia means less than 30 causes vasoconstriction, so should not be tried. Hyperventilation has got no role. Only in the initial 3 hours, if for the as a salvage measure, you should do. What you should target is PCO2 somewhere around 30 to 35. So, and get an ETCO2 monitoring so that you can have a dynamic range that what is happening with the patient. This is much important than keeping the oxygen in the normal range. So PCO2 is something which you should be very, very alert in such patient. Low versus high PEEP in view of ICP. Why I'm telling that? Suppose you have a head trauma patient and also cause a lung contusion, or also cause a trauma ARDS patient. You have a trauma which causes a ARDS, and also the patient has head injury. So you need to maintain the oxygenation. So you need to provide high PEEP. So whether you should, what happens when there is a high PEEP, there is a raised intrathoracic pressure, and because of raised intrathoracic pressure, the venous drainage from the brain gets lowered, and there is a raised ICP. You cannot drain the blood. So whether we should be not giving PEEP to this patient. So what they argued that if we are not oxygenating the patient, then it is further damaging the brain. So you should not concern about it. You can keep high PEEP. Second argument was that because the lung is so stiff, the high PEEP is not translated to the lung tissue or to the brain. So even if lung is stiff, so that PEEP will not hamper the ICP. So if you need to go for high PEEP, you can give PEEP. And for that matter, proning is a raised ICP is a contraindication to for proning the patient in ARDS. But if we are not salvaging the patient, anyway, it's going to damage. We are going to lose the patient. So proning also in control environment can be done. Glucose level. How much should be the glucose level? Very interesting. So we know that the tight control of sugar is obsolete. Because hypoglycemic episodes are more detrimental to patients. So somewhere around 180 to 200 is something which is recommended for all critically ill patients in the ICU. Now, for neuro, do we still need a strict control somewhere around 110, 120? So the argument was that because of the raised ICP, because of the raised pressure, the glucose and the blood which is going to the tissue, which is dying, or there is a penumbra, or there is edematous tissue, it receives a lower amount of glucose as compared to the normal parenchyma. So if we reduce the sugar levels too much, 120, 130, 140, we reduce it, then the tissue which is already damaged, where there is edema, it will not receive the proper supply of glucose. So the like all critically patients, maintaining blood glucose level nowadays somewhere around 160 to 180 or 180 to 200 is fine. You should not target for low glucose levels. DVT prophylaxis, very, very important. Patient on ventilator or patient cannot able to move because of traumatic brain injury. So mechanical pneumatic compression devices should be started within 24 hours. And if after 24 hours there is no risk of bleeding, or there is no, after 24 hours you can switch to start the pharmacological ones, in either in terms of heparin 3000 or low molecular weight. Both are same. And if you have done a surgery of the patient, so 48 hours beyond the surgery, if there is no risk of further bleeding, everything is fine, you should start, you can start low molecular weight or medical pharmacological prophylaxis. Very, very, very important, especially in the initial hours of pre-hospitalization, pre-hospital transport, antifibrinolytic therapy. The CRASH 3 trial showed that in traumatic brain injuries, the CRASH 3-1, if we give tranexamic acid as 1 gram bolus over 10 minutes and then 1 gram over followed by 8 hours within 3 hours, then it has an impact on mortality. So tranexamic acid initially should be given to all patients whom you feel this is in the initial stages, and we can give tranexamic acid. Early versus late tracheostomy, whether we should do within 7 days or after 7 days. So no impact on the long-term outcome, but very good amount of impact in ventilator associated pneumonia, very good amount on lower length of stay, very good amount on low sedation protocols. So early tracheostomy is recommended. If you are thinking this patient will remain on ventilator for a longer period of time, get it done as early as possible, after surgery, during surgery, and within 7 days. This is something which you need to consider very aggressively. Blood transfusion target, whether we should target above 7 or above 10. So both less, more than 7 means restrictive, or more than 10 means liberative transfusion strategy was there. So if it is a shock patient, you obviously you will transfuse, but if your patient is hemodynamically stable, so both, some people manage both the things, given both the things. So they found that though there was no specific benefit of maintaining hemoglobin around 10, but in the arm where the hemoglobin was maintained 10, a little more component of ARDS or acute lung injury was a little more. So there is no deviation from the routine management of protocol, that above 7, if the BP is maintained, you can target that only. Antibiotic prophylaxis for aspiration, whether we should give antibiotic prophylaxis for aspiration. So in this, we don't give for routine, but for this set of patient on traumatic brain injury, because we assume that the patient must have aspirated something. So ceftriaxone 2 gram BD is something which is the recommendation in all the guidelines. Those patients whom you feel that this patient is traumatic brain injuries, there is risk of aspiration, start with ceftriaxone 2 gram BD. Advanced neuromonitoring I have already does. And anything else from your side, we'll see in the chat box. Thank you.
Fantastic presentation, Ankur. And there are lots of questions for you also. A lot of them pertain to, whether hypertonic saline and mannitol can be given together. And I just want to say my 2 bit of this. The problem with mannitol is that when you give mannitol, do you give 20 grams, 40 grams, 60 grams, 80 grams? What do you give? And what is the resulting osmolarity of the serum that you get with it? Unless you're doing ICP monitoring, it becomes very difficult to know. Your target osmolarity that's shown to be best is around 300 to 310 milliosmoles. Now, if you use sodium, serum sodium, a serum sodium about 150 will give you an osmolarity of around 310. So it's something that you can use if you do not have sophisticated intracranial pressure monitoring, that you target a sodium of 150, 155, and you should be fine with that. So that's one important issue. Second is, if you have, this is your 2 halves of the brain, all right? This part is injured, this part is not. So where will the blood-brain barrier be intact? Here, which is not injured, all right? And the injured part, where there is no intact blood-brain barrier, your hypertonic solutions will not work. So what happens? Where you have an intact brain and the blood-brain barrier is working, your solutions will cause cerebral, you can call it dehydration or shrinkage because of the water being pulled out. But in the damaged area, that will not happen. So what happens as a result is the damaged area actually, you get a shearing injury because it moves towards the side of the normal brain, and the normal brain is actually shrinking. So that's something you have to be very cautious about, of not giving too much of hypotonic material there. and therefore be very cautious combining mannitol and 3% saline. Questions, your comments, obviously, and then I'll go on to the other questions.
I think someone asked about mannitol and glycerin together, Ankur.
Before coming to that question, what sir has told exactly, I am quoting the line from the text, which is the latest one. So what sir said is very right, and you should be very, very cautious regarding, especially in the EDH patients. Mannitol has been shown to preferentially shrink the brain tissue where the blood-brain barrier is intact, because it will shrink where the blood barrier is and it will leak in the injured part. But at the same time, it is also showing, though it has been shown that midline shift does not increase with mannitol's use. But this is a general statement. You should be cautious while giving. If you find something, maintaining with hypertonic saline is a better option as compared to thing. Can mannitol and 3% be used together? Technically, there is no head-to-head, or there is no data or something which shows that both of them can be used together. I basically, you are targeting the osmolality of the intravascular compartment. So no point in combining. It will not give you a better effect per se. For the sake of that, you may give, but why to give mannitol along with 3% if you are able to manage ICP, and why to land in complications of mannitol if you are already giving a hypertonic saline? Then the second question is, after decompressive craniotomy, do we still need to give mannitol or 3% saline? Usually it is not recommended, but what our protocol, what we follow is, we get a surgery, and the next within 12 hours we get a CT scan done. If there is a midline shift has resolved, and we stop it, it's not of much use, because the purpose of craniotomy was that, and we start tapering off. So, but if your patient is having hyponatremia, if the sodium levels are 130, 135, then you should continue, so that you maintain a somewhere of osmolarity and sodium levels somewhere around 1 to 45, which is a comfortable range. Then third question is, when should we give seizure prophylaxis? Already covered in the session. Which medication is preferred? Your choice. There is nothing but levetiracetam is something which is preferred nowadays, though it only concerned with is it can cause slight agitation, it can cause slight hyponatremia. If it is there, you can switch to another one, either phenytoin or valproic acid. Any biomarkers that can show the severity of brain injury? So there are some advanced, not biomarkers, but there are modalities which measure it. There is a brain tissue oxygenation, jugular venous oxygenation. What they see is the venous drainage which is coming back from the internal jugular vein, jugular venous sinuses. They see the oxygen saturation. If the oxygen saturation is if there is not good, if it is desaturating, means the brain is not getting proper oxygenation, and because of the cerebral perfusion is compromised, and because of raised ICP, so it is something which is there. Another, brain tissue oxygenation. So this was indirect. They were treating in the brain. They put a probe inside the brain and monitor the brain tissue oxygenation. If it is less than 15, that means there is a desaturation in the brain which is causing. Then there is a term which you will read is microdialysis. Microdialysis means there are four parameters, four things which they use in it. And to be very specific, let me quote you. The four things are, they allows measurement of extracellular glucose, lactate, pyruvate, and glutamate. So if lactate pyruvate ratio is greater than 25 to 40, is suggestive of anaerobic metabolism. So they put a probe there. They measure the extracellular glucose, lactate, pyruvate, and glutamate. So if the lactate is increasing in comparison to pyruvate more than 25 to 40, this ratio, that means anaerobic metabolism is there, and that therefore it can compromise. This is a sign that there is a cerebral perfusion pressure is compromised. But still, not much data is available. But because you asked this microdialysis, cerebral microdialysis, you should be aware. If my patient has head injury with intra-abdominal bleeding, how do you approach such a case? So depends. Obviously, you need to transfuse. Obviously, you need to see which is life-threatening. If you are taking the patients for, if the patient is bleeding per se, obviously you need to go for surgery. So for that matter, still maintaining a blood pressure of around systolic blood pressure of 100 is recommended, because all the such patients were excluded from the trial in permissive hypotension. Earlier, we used to maintain the blood pressure around 100, but because of the new guidelines in trauma, they came up with this permissive hypotension, damage control surgery. But if a patient has traumatic brain injury, what's the point in saving a patient and making it vegetative lifelong? So that's the concept. So keep a systolic blood pressure of 100, 110 in such patient, and take care of the other things which are causing the bleeding. So this answers Moises. Anything other? Let me check. Role of mannitol and glycerol as a combination. Technically, it is nowhere mentioned if you ask. And the combination, if you go to that combination bottle, the concentration are less as compared to separate ones. So if it is not practically very well, but just for the sake it is there, many people use it. It has got no harm per se. That's why it is there. And usually glycerol is used in condition where is technically no raised ICP. Patient GCS is maintained, and where the surgeons feel that okay, we should have something. We maintain a little bit hypertonicity in the blood if we are not giving sodium. So that's the purpose. It's not very much
Very
effective.
much empirical and
Empirical.
yes, it's not scientific.
If there are signs of impending herniation, even after immediate measure to reduce ICP in an outer hospital, can burr decompression by an intensive? No, not recommended. Absolutely not recommended. This is something which is beyond my answer, and it's technically medically also not recommended. Comparison of 20% mannitol with 10% mannitol with combination. No, nothing. You need to give it 20%. Basically, what you are giving is mannitol, 20% or 10%. The grams, calculate the dose of mannitol, 1 gram per kg or 1.4 gram per kg. If it is a raised ICP, the standard dosing you give 1.4 gram per kg body weight. Suppose it is a 60 kg, so you need to give somewhere around 90 or 100 grams of mannitol. So 20% means 20 gram is there. So you will require 5 vials. If you are giving 1 gram of mannitol, if you are giving 1 gram of mannitol, that means 60 grams. So you will require 3 bottles. If you are giving 10% mannitol, you need to require 6 vials. So dose is important rather than the percentage. But most of the time it comes in the 20%. So calculate the dose and give it that way. If a patient is AKI and CKD in hypernatremia with raised IP, is hypersaline okay? Yes. Hypertonic saline is preferred. Then I think parasympathetic stimulating activity, PSH, that's what you mean by it. It's a thing which is there present in parasympathetic activities there, PSH, that's what I can get it. So it is obviously observed in traumatic brain injury, but there is no standard guidelines. You need to maintain sedation. You need to try drugs like beta blockers if it is permissible. You need to maintain hydrations. You need to use anxiolytic, that sort of medication. No standard guidelines, but you need to manage it that way. Triple S therapy, no role. Nowadays, it was there for subarachnoid hemorrhage, but still this has gone out of favor. How to differentiate between central infections, fever, bromocriptine? It's a very detailed topic, and you need to obviously rule out the chest lines, tubes, aspiration. It's very, if you don't find anything, you can take care of example of lesions where if there is a lesion is somewhere around the hypothalamus, pontine bleeds, somewhere is there. It is more chances that the fever is of central origin. Initial days, worst day, second day, high grade fever, refractory to therapy, usually central. If it develops third, fourth day, there is CSF rhinuria, there is aspiration, there is shadow on the X-ray, then you think that this is something because of infecting. EVD fluid, how much to drain? Depends upon the condition, how much the surgeon feels comfortable. We need to drain depending upon the ICP. There is no standard thing which we do. But like in one shot, if we need to, they remove 20 ml and see, we remove 30 ml and see how is the GCS, or they remove this particular period over a period of time. That's the thing. How to taper off mannitol? So I think I have answered this question somewhere else before. No specific guidelines per se are there, but the point is to reduce gradually, and it is not mannitol is not helpful beyond 8 days. If you are giving mannitol beyond it, absolutely no use, because there is a synchronization. I think the term which they use is ideosmoles. Ideosmoles are the things which the cells develop inside their intercellular compartment to fight with the osmolality variations in the extracellular fluid. So if you are tapering off mannitol beyond 8 days, anyway, you can do that. But the thing is, just to prevent the rebound hypotonicity, it is tapered in a gradual way, like TDS, then BD, then OD, and like that. But it is to Trenexa, I have told you, it's a very important role. Early late tracheostomy, we have discussed. We have also discussed what antibiotics, ceftriaxone, 2 gram BD stat. Management of central fever responding to paracetamol, cold sponging, anything you need to try. There is no other molecule which can take care of paracetamol of the fever. Which osmotic agents of choice in pediatric? Sorry, pediatric age group was not the concern. Means what we are discussing is not pediatric; it's adult critical care. Magnetic or CKD patient, routine dialysis, no. How much more damage will CKD? No. Why do you use a CKD patient if you want to use mannitol? Or if there is a patient is on maintenance dialysis, see, understand that if in a CKD patient who is already on hemodialysis, then there is no point of preserving the kidney. So if there is no point of preserving, you can use anything. It's the patients who are CKD, who may land in dialysis, who may are developing renal failure. You want to prevent that, then there is a role of hypertonic saline. So if already the patient is on dialysis, what's the point of preserving the kidney? Do you prefer neuroanticoagulants like rivaroxaban over heparins or DVD prophylaxis? There is absolutely all nobody is superior one over the other. But once the patient is still the guidelines say low molecular weight and heparin, because they want to use such a molecule for which at least there is a antidote is available where they can reverse it in case something happens. So there is no what I would say is preference of one over the other. Trial extubation in patient in moderate with good cough and gag, case to case basis. Trial extubation is something which moderate GCS, 8 to 9 GCS is something very borderline. At the GCS of 8 or 9, you intubate the patients in sub patients. So poor cough, good cough and gag are one of the criteria, not all the criteria. I would still go for tracheostomy in such patient. Trial extubation and put the risk of aspiration like that. Then Ram Krishna Pandey, if brain herniation seen, what should be done and how to maintain CCP? Brain herniation, I think Ram Krishna is from my unit also. We had a case where there is a brain herniation from the nostrils, and that it's already a patient which has gone beyond a certain stage of recovering, and this patient will land ultimately in apnea. You need to just prevent cosmetically, and how to maintain CEP is regarding cellular perfusion is what we have discussed before. Any role of dexamethasone already told, no steroid avoided. Who is Dr. M. Pasha? I just want to know that he has either read the chapter or not understood anything from the chapter. And what is in TBI target sodium level 145? It's better to keep it above 150, 155. Do we have a role in monitoring serum osmolarity rather than serum sodium monitoring therapy? See, basically, ultimately, you are measuring the osmolarity, but you cannot measure it very frequently. Sodium gives a dynamic idea about, because you're targeting the therapy based on that. That's the thing. And what you get in ABGs and other things is a measured one, sorry, calculated one, not the measured one. So if you have a measuring device in your ICU or measuring machine in your ICU, then it has a better chance of monitoring as compared to sodium. Obviously, if you have a measuring thing, it's better than sodium monitoring therapy. Neuromuscular, yes. Can neuromuscular blockage used to prevent TBI? No. TBI, traumatic brain injury, we cannot prevent traumatic brain injury. But yes, if for controlling the ICP, you can take care of neuromuscular blockage, and they are very, very helpful, especially the cis etracurium as compared to etracurium, along with sedation and analgesic use of neuromuscular blockage have a very good role. So you need to use cis etracurium or etracurium along with that with sedation. It helps to prevent decrease the raised ICP. How frequently to monitor PCO2 or continuous ETO? Obviously, this is a Dr. Pasha, this is a logical question. If you have ETCO2, it is there on the monitor. You are monitoring regularly, so it's a better as compared to ABG. Oral glycerol, I have told, it's no role. If there is no indication of surgery in TBI, then when we'll start taper on monitor. Mannitol beyond 8 days is not helpful. And if the ICP is not decreased on till day 8, chances are it will not decrease. It's similar for the 3%. It's the initial 4 or 5 days which are very crucial. And after that, the body tries to decrease the ICP. Does mannitol help in preventing free radical injury? I don't think there is something related to that. I think, madam, I had not covered 3% saline dose to reduce ICP because most of the literature is
I tell you,
talks.
Ankur, it's very simple because when you listen to the sodium talk, if you know what osmolarity you're targeting and you know the weight of the person and you know the existing sodium, it becomes easy to calculate how much you need to really give saline. There's one more comment I want to make is that in my experience, there was a phase in between when I was at Lilavati Hospital heading the unit that we had a series of patients come in who were unconscious for 2 months. That was the admission criteria, not recovering after traumatic brain injury for 2 months, and they would get admitted. And we wanted to see what we could do for them. It was very gratifying because most of them regained very good functional recovery. Sometimes it took 2 months, sometimes 4 months, sometimes 6 months, and the longest was 1 year, 1 month, and they went back. This 1 year, 1 month was an engineering student who went back and completed his engineering there. But the only differentiating between of those who recover and those who don't is younger people, age more than 40, 45, they tend to do well. And if you're older than that, then the chances of recovery are not as much. Maybe they have better reserve, whatever. The other thing, of course, will be the extent of injury. But if you're unconscious for 2 months and not recovering, don't give up hope in these people. And so that's something that's been my personal experience. And we did this for about 8-9 patients unconscious for more than 2 months after traumatic brain injury.
Okay, thank you, sir.
Sir, I put it across the, of course, we have a session on how to increase the sodium by sodium correction. But when it comes to reduce the ICP in patients of traumatic brain injury, then the various articles say you give bolus. So that's what bolus, they have not specified it in many places. Only couple of articles I came across that it could be anywhere around, because we give mannitol bolus over, say, 30 minutes. So I suppose even the 3% saline in that initial period where you are expecting the coning or brain herniation or extreme raised ICP, and there they've given the dose as 1.5 to 2.5 ml per kg as a bolus. So most of the guidelines have shown this as initial bolus, and later on you continue infusion to target, of course, around 150 plus sodium.
Okay, thank you, madam. Now, Dr. Pankaj has asked a very good question. That's how to monitor the depth of sedation if neuromuscular blockage are being used you need a continuous EEG monitoring device for that matter. In the depth of sedation can be monitored according to that. That's very, very important. And the same, of course, Mohapatra has thought that if neuromuscular blockade with adequate analgesia and sedation is counterproductive. Yes, the sedation should be deep enough. Only then neuromuscular blockage should be there. It should not be opposite. The neuromuscular blockage is high and the sedation is not given. They should always be used along a deep sedation, the neuromuscular blockage. And one more thing, this I read decompressive laparotomy, found it interested, though the trial did not show much. But that I have covered. It was decompressive craniotomy. So it is basically DECRA trial or other trial they are quoting it. That though the survival was a little high, although the inclusion exclusion criteria there are lots of controversy in which patient they included. I think there is a one more trial, rescued sort trial, which is come after that, which has corrected certain aspects. But all of them found that though the survival has increased, the neurological function outcome have not increased. In fact, they are more dependent on the nursing homes and the nurse hospice and something. So I read about decompressive laparotomy. So how it is relevant to today's talk, I'm not still getting. Maybe you can put it on the WhatsApp. And then if TBI patient becomes hypertensive, what type of antihypertensive? What what should be used rather than what is important, what should be used, you should know what should not be used. So if in hypertensive patients in traumatic brain injury, or for that matter any neuro patients, don't use nitroglycerin sort of thing, nitrates, because they are venodilators and theoretically they can cause raised ICP. So you should go for either, if the patient can take orally, you can give any of the APC drugs, or if not, then labetalol is something which is recommended. But still you need to take care of the heart rate, because there is slight caution in it, because obviously it's a beta blocker, so it can hamper the heart rate. But for all practical purposes, what we have seen that until unless you are giving in very high doses, labetalol does not affect your neuromonitoring to that extent, so it's a safe thing. Ketamine, I think, should not be used because it causes ICP. And enalaprate, if the renal function are okay, you can try that.
Okay, it's been 1.5 hours, Ankur. I think we've had a very good question answer session.